Good morning, everyone. My name is Dr. Trisak Kingchan, a sport medicine orthopedic fellow at Prince of Songkhla University. Today, I am honored to present update glenoid component of anatomic total shoulder arthroplasty. This presentation is a part of our fellow lecture day, and I would like to acknowledge my advisor, Dr. Prabhakar Kapklai, and Dr. Chaiwat Chechuskun for their guidance and support. The foundation of modern total shoulder arthroplasty was established by Charles Neer in 1974. Neers introduced the first generation of total shoulder arthroplasty, which featured of a monoblock humeral stem and a Q or polyethylene glenoid prosthesis. By 1982, Neers and colleagues published a case series demonstrating that improved range of motion and functional outcome. Since then, the total shoulder arthroplasty has gained widespread acceptance globally. Several studies have confirmed the long-term success of total shoulder arthroplasty. Before we proceed, let me ask you a question. What do you think is the most common cause of failure of the total shoulder arthroplasty? Is it infection, implant wear, or instability? The most common long-term complication of total shoulder arthroplasty is the glenoid loosening, accounting for 24% of our total shoulder arthroplasty failure. In 1988, Franklin described the rocking horse effect as a key cause of glenoid loosening in total shoulder arthroplasty. This occurs when uneven loading leads to compression on the one side and distraction on the other, causing the progressive micromotion at the bone implant interface. To reduce glenoid loosening, various implant designs have evolved over time. The three main types are all polyethylene cemented glenoid, seamless metal back glenoid, and the hybrid glenoid. Key improvements focus on the conformity, shape, and fixation. Glenoid conformity plays a crucial role in the implant longevity and the stress distribution. For the conforming glenoid component, provide uniform stress distribution and reduce abrasive wear, enhancing implant longevity. In contrast, in non-conforming design allow for greater translation and reducing edge loading. Walls in 2002 found that the radial mismatch of 6 to 10 mm optimally reduced radial lucency. All polyethylene glenoid components come in two primary shapes, convex shape, and a flat back design. Biomechanical studies show convex back glenoid design provides superior pull-out strength for the long-term fixation. The clinical study found that convex back glenoid have a significantly lower radial lucency rate. There are two main fixation types for all PE cemented glenoid component. The Q glenoid, first introduced by Neer, have a high rate of radial lucency, and the PEG glenoid requires subchondral bone resection and achieve stronger fixation in peripheral bone. In 2019, systematic review and meta-analysis from GSES compared the Q and the PEG glenoid. The study found that PEG fixation has a significantly lower revision rate. This finding suggests that PEG glenoid may provide better long-term implant stability. A study in 2017 analyzed the inline PEG glenoid. Results show high radiographic failure and a high clinical failure, with a higher radiographic loosening compared to the Q glenoid. The study concluded that the inline PEG design mimicked the Q fixation. Based on this finding, peripheral PEG glenoid are suggested as they provide a better fixation. Due to the high failure rate from the glenoid loosening, the bone-in-growth glenoid design was developed. This design features an all polyethylene component with a flank central peg, which promote the bone ingrowth and enhance the osseointegration into the glenoid wall. A JBTS study in 2016 reviewed the all-PE glenoid bone ingrowth design. At an average follow-up of 4 years, patient has an excellent clinical and radiographic outcome. Minimally radial lucency was observed, and 81% of cases achieved the complete osseointegration on CT. Only one revision due to the aseptic loosening was reported, confirming the implant strong fixation and long-term durability. In 2019, Messen analyzed 1,000 patients across the 11 centers. The glenoid design of the cemented peripheral peg and an uncemented foot central peg. The clinical score shows significant improvement at 1 and 2 years post-operatively, highlighting the effectiveness of this fixation technique. A study in 2020 examined the 6-year cumulative revision incidence due to the glenoid loosening. The lowest revision incidence was observed in the central peg ingrowth design with only 0.8%. This finding highlighting that central peg ingrowth design offers superior long-term stability. Due to the high rate of glenoid loosening from the RPE design, researchers developed the metal back glenoid as an attempt to improve glenoid fixation and reduce the radiolucent line. The goal was to enhance implant stability and minimize the risk of long-term failure. A case series published in 2009 analyzed 6 different glenoid component types over the mean follow-up of 7 years. The study found that RPE glenoid had a low revision rate, while the metal back glenoid had a significantly higher revision rate of 10%. This finding suggests that the metal back glenoid are associated with a higher failure risk compared to the RPE design. In 2014, JBTS systematic review compared metal back and the RPE glenoid component. The study found that metal back glenoid had a lower radiolucency and radiographic loosening. However, the revision rate from the metal back glenoid was significantly higher, suggests that the RPE glenoid component provide a better long-term survivorship. For the metal back glenoid, failed due to the insufficient polyethylene thickness, excessive of component thickness, and a high rigidity, which accelerate wear and stretch chill to the bone. This factor contribute to the higher revision rate compared to the RPE design. To address the thickness issue of the metal back implant, soft metal back glenoid component were developed. A case series examined the soft metal back glenoid component with a multiple layer of alloy titanium mesh. The study reported early complication in 13% of cases, including the broken peg and the metal debris. The modern evolution of metal back glenoid include the monoblock porous tantalum design. This component offers 2 key benefits. First, the monoblock structure prevents backside wear, and second, the porous tantalum cube promotes stable bony ingrowth. First generation of tubercular metal back glenoid was introduced in 2003. A 2013 JSCS case series with the average follow-up 3 years for this design, the study found a 21% failure rate due to the fracture at the cube glenoid face junction, leading to an unacceptable high rate of glenoid failure. Due to the high failure rate, the first generation were redesigned. In 2009, the second generation version was introduced, featuring 2 additional posts, anterior and posterior. The study in 2016 reported the excellent clinical outcome with a 3-year follow-up and with the radiolucent line in only 5% of patients. A systematic review in 2020 compared the modern design metal back glenoid patient with the RPE design. The failure rate showed no significant difference before 72 months, but after 72 months, modern metal back glenoid design had a lower radiolucency, loosening, and failure rate compared to the RPE glenoid. This finding suggests that the modern design of metal back offers more stable in the long-term fixation. Another RCT in 2021 compared second-generation tubercular metal glenoid with the RPE glenoid over 2 years. There were no implant failure or revision in either group. For the hybrid implant, combine the initial fixation of the cemented polyethylene peripheral peg in the long-term biologic fixation from the bony ingrowth central peg. This implant features an uncemented central metal post or cage that promotes the bone ingrowth, enhancing stability and durability. A retrospective cohort study compared the hybrid glenoid and the RPE glenoid. Hybrid glenoid demonstrated a better long-term stability with a lower radiolucency, less loosening, and fewer revision, support their superior fixation and durability over the time. A 2021 systematic review analyzed the total shoulder arthroplasty with the hybrid glenoid design over the mean follow-up of 4 years. The study reported a radiolucency rate of 33%, glenoid loosening about 0.7%, and a revision rate about 2.5%, but the long follow-up is needed. In the recent years, several innovative glenoid implant designs have emerged to address the glenoid deformity and the complications that associate with the early glenoid design. The posterior augment glenoid, the inlay glenoid, and the convertible glenoid were developed to enhance implant fixation, longevity, and adaptability. For the severe glenoid retroversion is a negative predictive factor for the clinical outcome in total shoulder arthroplasty. For the retroversion less than 15 degrees, correction can be achieved with the eccentric anterior reaming. However, correcting more than 15 degrees with the reaming alone may risk of peg protrusion to the glenoid wall. For the retroversion more than 15 degrees, terminal options include using a standard implant with a bone graft or a posterior augment implant to restore the proper alignment. For the posterior augment, these implants are available in the full wedge, half wedge, and a step cut design, offering the correction range from 5 to 15 degrees. A JSES case series in 2022 analyzed the posterior augment glenoid design to evaluate the retroversion correction. The studies show successful correction of the retroversion and improved in the posterior subluxation. Notably, there was only one case of glenoid loosening, suggests that the proper correction strategy contribute to the disc implant stability and improve the outcome, and have the good result in the midterm. For the inlay glenoid, utilize the rim fit of subchondral bone for enhanced stability and reduce the edge loading by not resurfacing the entire glenoid face. A study in 2023 evaluated the inlay glenoid implant for the severe retroversion and bone loss. A 2-year follow-up complication includes 5% of radiolucency, 1.3% of glenoid loosening with no revision report. This result highlights the potential benefit of the inlay glenoid in the managing the glenoid deformity with a promising early outcome. Removing a cemented glenoid component caused the bone loss and complicating the base plate implantation. The convertible glenoid implant help preserve a well-fixed component when converted from total shoulder arthroplasty to the reverse shoulder arthroplasty. A case series in 2021 on the convertible glenoid implant over a mean follow-up of 4 years. Clinical include 8% of radiolucency, but no failure were reported. For patients with a rotator cuff deficiency, was successfully converted to reverse shoulder arthroplasty without complication, suggests good midterm result. And for the take-home message for the updated glenoid component for the anatomic total shoulder arthroplasty. For the OPE, central peg in growth design has a long-term stability with a low revision rate. For the metal back, second generation topicular metal showed a promising midterm result. For the hybrid design, lower revision, better early fixation, but radiolucency is still concerned. For the posterior augment design, ideal for the retroversion more than 15 degrees, have good midterm result. The inlay design, less wear, bone sparing, but need more study. For the convertible design, allow conversion to the reverse total shoulder arthroplasty with no complication and have the good midterm outcome. Thank you.